Bismillahirrahmanirrahim. I think it's good morning or good noon. It's maybe good morning. So, first of all, I am thankful to Professor Salman Sharif for giving me opportunity to talk on this complicated subject. I belong to Nawabshah where these gadgets are lacking. We don't have CUSA, we don't have intraoperator monitoring, we don't have the navigation system, but we have simple tool, that is the bipolar, the suction, operating microscope, and a drill. And we have got a hand. They say that in hand you have got 50 joints and you have got million movements. Before, I think, learning the gadgets, we should learn how to use our hand. Our hand is very important. So we are using hand and we are showing our results, our ignorances, our defects, and we want your help to assist us. So what we have found that we don't find small acoustic neuromas. We find large acoustic neuromas, the giant one, because people don't want to be operated unless they get unconscious or they get fell down. So they come to us when they have got a big tumor and they are in a very bad shape. So everybody knows acoustic neuroma is a misnomer. It's not neither neuroma nor it is neurofibroma. It's a schwanoma. It's arising from the inferior division of the vestibular. That is why it is called vestibular schwanoma. I don't know why sensory nerves have more schwannomas. I don't know why the vestibular and cochlear nerve, they function together. And I don't know why the seventh nerve is in a bad company of eighth nerve. Everybody, I think if anybody has an answer for that. And everybody, the engineers know the differential diagnosis of the acoustic neuromas, the epidermoid, arachnoid cyst, the schwannomas, and the treatment options, everybody knows microsurgical resection or stereotactic radiation, observation, and chemotherapy. We observe in elderly patients, in patients with small tumors, especially if their hearing is good, patients with medical condition that significantly increase the risk of operation, patients who refuse treatment, patients with a tumor on the side of an only hearing ear or only seeing eye. I consider that acoustic neuroma is as same as neurofibroma anywhere. It has got a nerve root, it has got a blood supply, it has got a venous drainage. If you know the pathoanatomy of the acoustic neuroma, you can handle it very. And I know there are two types of neurosurgeons in the world. One are handling, they are playing like a cat, and the other they are attacking like a lion. So you have to see where have to play like a lion and where to attack like a cat. And everybody knows it arises from the junction of the central Schwann cells and the central myelin and the peripheral myelin. Central myelin is formed by the oligodendroglyocyte, peripheral by the Schwann cells. The bad thing about eighth nerve is that this junction is far away from the brainstem and it lies in the internal auditory meatus. So that is why I am giving importance that the internal auditory meatus has got a great importance in the management of acoustic neuroma. If you don't deal with the internal auditory meatus, you will not be able to preserve the facial nerve or you cannot completely resect the tumor. It's a prime importance. Everybody knows the tumor classification, grade 1, 2, 3. We receive all these in grade 4. They have got severe brain displacement and deformation of the fourth ventricle with under tumor compression. So you can see that there may be such large tumors with brainstem pushed on the other side, and the ventricle is compressed. They usually present with the hydrocephalus, and sometimes we find the bilateral acoustic neuromas. Such big tumors, you can see that the brainstem is so compressed. They come with cranial palsies. They have got glossopharyngeal vagal and accessory involvement, and they need NG tube. They even need tracheostomy. They even need preoperative shunting or preoperative endoscopic third ventriculostomy. So you see this patient as seem to be hydrocephalus, but if you look carefully, they have got bilateral acoustic neuroma. If you give them contrast, this is so they come in a very bad shape. Such the brainstem is squeezed between two tumors. So NF2 is another misnomer. It's not neurofibromatosis at all. It is Schwanoma. It is not neurofibroma. And everybody knows the formula of two. They involve in the two acoustic neuroma. They involve two eyes, and they involve the two parts of the brain, the ependymoma and the meningioma. People all over the world talk about hearing preservation and facial nerve preservation, but we talk about life preservation because they coming in a very bad shape. We think of their life. We want to preserve their life because of brainstem compression. They have cerebellar sign. They even go to interrespiratory depression. They have lower cranial palsies, and there is obstruction of the circulation. And for that, we prefer to do ETV or VP shunt. We had 3 patients with NF2, and they were totally blind and totally deaf. So how they were communicating, I was expecting how they communicate with other person when they are totally blind and totally deaf. One patient was operated on both sides and recovered, but no improvement in VN. I've seen that when you operate, they don't have improvement in VN. And one patient had operation on one side and presented after 6 months and died due to respiratory problem. One patient had surgery on one side, and he is waiting for operation on the other side. Everybody knows about 3 approaches, but we only do sigmoid. We are only aware of that. We don't know how to do translabyrinthine and middle fossa operation. Different people, they have different approaches. I think the world over, the world champions in neurosurgery doing acoustics, they prefer sitting position. But I think in Pakistan, we are not adopting this sitting position. Sitting position is not done. We prefer 3/4 prone position. We find it's very good for approaching that. As everybody knows, axillary low pressure points are padded, chest and hips are straightened, shoulder is gently retracted. And I think it's a great preference given to the placement of the shoulder. Where is your shoulder lies? If you are operating on an acoustic for 5-6 hours and your shoulder is coming in your way, that will be a great problem for you. If you displace your shoulder anteriorly, it will be easy for you.
Sir, we have 1 minute.
So we don't have monitoring brainstem or facial nerve monitoring. We don't have untitled PCO2. Eyes should be take care. They should be take care of the DVT. So people do craniotomy or craniotomy. We do craniotomy on this, and it is easy to do craniotomy. And then that bone can be repositioned afterwards. And if your craniotomy is flushed with the petrous bone, then you will avoid great cerebellar retraction, because cerebellar retraction gives you cerebellar continuance and post-op patient get worse. So your craniotomy should be flush with the petrous temporal bone. And there should be opening of the cisterna magna or cisterns to get relaxation of the cerebellum. And sometimes some part of the cerebellum can be resected to avoid gentle retraction. Internal auditory acoustic meatus, I think this is the drilling of the acoustic means is very important, and it should be learned how to do internal auditory meatus. I divide into one stage you do tumor bulking, then you second stage is you go to the internal auditory meatus and you drill it 5 to 10 millimeter. That gives you extra benefit. You find seventh nerve above the glossopharyngeal nerve, and then you come to the internal auditory meatus, you drill it, and you remove the tumor and you identify the nerve, then you can save the facial nerve. Otherwise, the facial nerve preservation is very difficult. Even after drilling of the internal auditory meatus, it should be waxed, it should be proper, either maybe CSF leak through that. Endoscope can be used to visualize the internal auditory meatus, and you see the structures inside. People say that if that some part of the tumor is stuck to the nerve, they can be left behind and sent to the gamma knife or other procedures. So this is our position. We keep the patient in somewhat lateral position and place the shoulder anteriorly. And we have got a support for our two hands. When you are operating in microscope and you are handling like that, you must have a support for your both elbows. Otherwise, you will get tired. And that is very important. So in conclusion, early detection of the tumor, preoperative management of hydrocephalus with VP shunt or ETV, proper position of the patient, debulking of the tumor, avoiding excess or use of bipolar. I still insist people, they use 1,000 times of bipolars in single acoustic. That makes the tumor like a charcoal. Your arachnoid plane is gone. You will inadvertently damage the nerves. So if you want to protect the nerve, don't use excessively bipolar. Drilling of internal auditory meatus is very stressful. Identification of the nerves at meatus near ninth and near pontomedicular surface. Post-operative care is very important, NG feeding and tracheostomy. That is very important in post-operative care. So thank you very much for patient listening this very basic talk after listening to very hi-fi talks. Thank you very much.